What is aspirin-induced asthma? Aspirin-induced asthma is a type of asthma in which aspirin and other non-steroidal anti-inflammatory agents precipitate bronchospasm, typically in susceptible individuals. Susceptible individuals often have underlying airway hypersensitivity. The condition is characterized by a reproducible reaction to aspirin and related non-steroidal anti-inflammatory agents, distinguishing it from typical allergic asthma. Mechanism: non-steroidal anti-inflammatory agents inhibit cyclooxygenase, leading to reduced prostaglandin production. This shifts arachidonic acid metabolism toward the lipoxygenase pathway, resulting in surge of leukotrienes, the key mediators of bronchoconstriction, mucus secretion, and airway edema. The classic triad: recurrent bronchospasm and airway hyperreactivity triggered by non-steroidal anti-inflammatory agents intake. Reproducible adverse reaction to aspirin and other non-steroidal anti-inflammatory agents. Patients commonly present with nasal polyps and chronic rhinitis or sinusitis. Asthma, aspirin sensitivity, and nasal polyps form the hallmark clinical presentation of aspirin-induced asthma, aiding diagnosis in susceptible patients. Management: strict avoidance of aspirin and all non-steroidal anti-inflammatory agents is the cornerstone of management. Paracetamol in low doses is a safer analgesic alternative for these patients. Montelukast is a key controller medication. In selected severe cases, aspirin desensitization may be considered under specialist supervision. What are biologics in asthma? Biologics for asthma are a class of lab-created monoclonal antibodies designed to treat moderate to severe asthma that remains uncontrolled despite the regular use of standard inhaled steroids and other controller medications. They disrupt the inflammatory cascade by binding to and neutralizing specific proteins or receptors involved in asthma pathogenesis. Patients with persistent, uncontrolled asthma despite optimized standard therapy, particularly those with eosinophilic or allergic phenotypes, are candidates for biologic therapy. Anti-IgE agent omalizumab blocks IgE, the antibody that triggers allergic reactions. Anti-IL-5 agents mepolizumab, rislizumab, benralizumab. They target IL-5, reducing eosinophil growth and survival. Anti-IL-4 and IL-13 agent dupilumab blocks signaling receptors for IL-4 and IL-13, reducing both allergic and eosinophilic inflammation. Anti-TSLP agent tezepelumab targets TSLP or thymic stromal lymphopoietin, an upstream molecule blocking inflammation early in the process.